Uh, Hello. Today we'll start the management of diabetic ketoacidosis in pregnancy, which is a talk article from 2017. While diabetic ketoacidosis occurs because of a deficiency in insulin and the concomitant rise in the counteracting hormones, that is cortisol, glucagon, growth hormone, and catecholamines. These hormones will cause lipolysis and proteolysis, which will result in gluconeogenesis, plus glucagon will result in glycogenolysis, and together these will cause hyperglycemia. Apart from that, the lipolysis will increase the free fatty acid levels to the liver, and it will increase the production of the ketones, and hence ketoacidosis occurs. Then there are certain physiological changes in pregnancy which is responsible for the causation of DKA in pregnancy. That is, normally in pregnancy the respiratory alkalosis occurs, which results in a compensatory decrease in bicarbonate levels, hence the buffering capacity is reduced and it results in increased acidosis. There will be insulin resistance and hence an increased lipolysis plus increased free fatty acid production. And number third, there is the human placental lactogen increase plus progesterone and plus cortisol, which results in the increase in insulin resistance. The certain precipitating factors for DKA are protracted vomiting, hyperemesis gravidarum, insulin pump failure. If the insulin pump doesn't work for a few hours, then the rapid acting insulin will not reach the blood and will hence result in DKA. Then gastroparesis, non-compliance to insulin, and there are certain drugs, for example beta mimetics, the beta agonist, which causes this. And then the infections. The sign symptom with which DKA patients presents are nausea, vomiting, drowsy, lethargy, abdominal pain, blurred vision, muscle weakness, respiratory rate will be high, there will be a high pulse rate, that is tachycardia, tachypnea, a low BP, that is hypotension, coma, shock, polyuria, polydipsia, there will be a change in the mental status or the abnormal fetal heart rate. We need certain investigations to diagnose the diabetic ketoacidosis, and we say that if the serum the serum ketone level is more than 3 millimole per liter, or the urine ketones are more than 2 plus, the glucose level is more than 11 millimole per liter, but this can be decreased in some cases. I mean normal in some cases. The arterial pH of less than 7.3, anion gap of more than 12, bicarb of less than 15 milliequivalent per liter, and the potassium will be falsely normal or elevated. The management of diabetic ketoacidosis actually consists of 6 steps, but before discussing that, I'll tell you that it needs at least a critical 2 care bed, which includes an HDU or an ICU. The team that is involved should have the obstetrician, anesthesiologist, endocrinologist, or diabetologist, and there should be a trained nurse and midwife. Large bore IV access should be gained, or the central venous line, and also the pulse oximetry should be there. Thank you very much. In the next video, we'll discuss about the 6 management steps for DKA.